Bismillahirrahmanirrahim. Good morning to our participants and our attendees. Uh, Thank you very much, Professor Paulson and Dr. Rajiv Mangla, for being with us at the 19th Shaukat Khanum Cancer Symposium, which is being held on a virtual platform this year. Uh, we are going to start our session with Dr. Rajiv Mangla. He is an associate professor of neuroradiology at Upstate Medical University, Syracuse, New York. He did his training at the Rajiv Gandhi Cancer Institute and Research Center in India, following which he came over to America and he did his fellowship in neuroradiology, advanced in neuroradiology and vascular interventional neuroradiology from the University of Rochester. His areas of interest are imaging of the brain tumors, advanced neuroimaging, protein imaging, and MR spectroscopy. Dr. Mangla, thank you very much for being with us and imparting your valuable time in the early hours of this Sunday morning. And we would love to hear from you. Over to you. Thank you.
Thank you so much, sir. My name is Rajiv Mangla, and I'm very sincerely for your kind invitation. I really appreciate it, and for giving me this opportunity to speak in this reputed conference. And I will be trying to speak on on the brain imaging, and I will try to cover some newer imaging techniques which can be used in the imaging of the brain tumors, and many of them we use in our day-to-day practice, and few of them are since it's a conference, as few of them are still used for the research purpose. We are not as much using them, but I will try to cover in brief so that everybody has idea what is new, which is in this field we are covering. So with this introduction, I will share my screen, and I will start my PowerPoint, and I hope you guys can see my PowerPoint.
Yes, we can. Thank you.
So I will cover imaging in brain tumors, and as you know, the nowadays if this is a very good chart showing how we as a imager, we as a radiologist mostly do this type of imaging, anatomical imaging, CT scan, MRI, and very few times, particularly in the brain tumors, as well as few other things, epilepsy surgery and other things, we also use functional imaging of the to map various areas of the brain. And as we know, the metabolic imaging is used by the PET scan people. We use it in neuro, not too much, but in cases of head and neck cancers, and sometimes in the imaging of the dementia, the role in that neuroimaging is very limited. And proteins imaging, the proteomics was a previous field. I have no experience about these, but nowadays there is a lot of interest in the field of radiogenomics, when the people are trying to find correlation between the radiological findings and genomics. So I will start with the the objectives of my talk is to discuss the role of advanced imaging, in cases of grading of the gliomas and diagnosing brain tumors other than gliomas, how to differentiate between them, how to differentiate tumor from tumor like brain lesions, and identify tumor recurrence, radiation necrosis, and peritumoral edema. It is a very long talk, but I will try to cover some areas, and if I am fast, please let me know. I will try to go slow. And I will try to speak on these modalities, MR perfusion, MR spectroscopy, diffusion, and diffusion tensor imaging, as well as functional MRI. PET scan we use, but not too much in the neuroimaging. So perfusion is I have I had like, opportunity to work on the perfusion imaging, like, we could little bit advance the knowledge of perfusion imaging. So that is my particularly area of interest. So please forgive me for like if my slides are heavily tilted towards the perfusion imaging, but like this is also truth that in brain tumor imaging, perfusion imaging has a big role. Like, we have like, whenever we have a question on routine MRI imaging, we try to do like our go-to modality is perfusion imaging. So I will talk like where can we use this perfusion imaging MR. We use DSC, dynamic susceptibility contrast imaging. Like, like this is a case of like, low-grade glioma type of picture, like non-enhancing tumor in cases of a in a left temporal lobe lesion, and we do perfusion, and indeed the perfusion is very low. So it was indeed a low-grade glioma. And now, like, this is a similar lesion, if you agree with me, like, there is no enhancement. But when we do the perfusion imaging, we see there is an increased area of perfusion, and increase, like, even in the non-enhancing glioma can be a GBM or like anaplastic astrocytoma. So that we can find out with the help of perfusion imaging. In this case, it was a high-grade glioma because of the increased perfusion. So similarly, like, it's a big enhancing lesion, but perfusion was very low in this lesion, and it was a pilocytic astrocytoma. So like the point here is like, within like, enhancing lesion, perfusion can be low, and within non-enhancing lesion, so it gives us information which is like, not simply given by the gadolinium based contrast imaging. It is a like, more functional imaging, like, it detects neoangiogenesis. If there is a neoangiogenesis, then we can see from the perfusion imaging. This was a pilocytic astrocytoma. Similarly, this is a lesion which is like indeed a low-grade glioma because of the low perfusion. So like, the cutoff is 1.75. If we have less than 1.75, we have a low-grade glioma. If more than 1.75 ratio, we calculate the ratio of the tumor from the normal brain, and then that is like 1.75. So in this case, like, the tumor is less than the less than the normal brain. So the ratio is about like, the 0.5, something like that. So this is a very low grade glioma. So similarly, like, we have a problem, like, sometimes differentiating between GBM and metastasis, and perfusion and spectroscopy has a role. Like, this is like multivoxel spectroscopy. We did like, as we all know, on the spectroscopy, we have to calculate choline to creatine ratio. If there is a high choline to creatine ratio, that means the lesion is malignant. But malignancy doesn't mean that it is we are still don't know that whether it is a GBM, metastasis, or lymphoma. Like, lymphoma are usually homogeneously enhancing lesion, but the necrotic proportion still is, we are confused between the metastasis as well as GBM. So what we do, like, the key here is to image the peritumoral area. Like, the metastasis has a very well defined margins. Here, like, you cannot tell the margins, but here on the perfusion maps, the margins are very irregular, ill defined. So they are like, they like, we saw that there is very high perfusion, and the lesion has irregular margins, and so that's why this lesion is a glioblastoma. And on the other hand, there is another lesion, like, the similar lesion, but if we see the perfusion maps, the perfusion maps has like, a very well defined margins. There is no infiltration into the adjacent brain parenchyma, as we saw in this lesion. Like, this particularly here, you see here, like, the lesion has very infiltrative margins, and it is going into the periphery of the surrounding brain parenchyma. So this is like, something which is like, can be used. And again, like, if we put our cursor into the it's a very high volume. The ratio is like, we can calculate the ratio. The number one is on the tumor, and if you see, the ratio is 8.8. So this is a very high grade glioma. So there is another thing which we can do, like, there is a, like, these maps has like, so what information we are getting, like, in the perfusion imaging is like, signal intensity time curve. what we do, like, in 1 minute, we scan the brain at least, like, every 2-3 seconds. And that's why we can plot this diagram, like, every dot is a like voxel, and we image it again and again. So here I am introducing one more concept, which is like recovery. And this is like, very interesting phenomena. We wrote a paper on this, like, and it is like, it became quite a bit of a popular paper, like, on the basis of this recovery, like, like of the, like, normally, if I show you, like, here, if I go back, you see here, like, the normal brain parenchyma is in the green. It comes back, like, to the baseline. But here in this purple color, it does not come to the baseline. Like, there is something wrong. There is something wrong with these vessels which they don't come back, so they are leaky vessels, and that's why it doesn't come back. So in cases of what we found, like, in cases of metastasis, and there was very less recovery. In cases of GBM, the recovery was better. And the reason for it, we know, like, the blood brain barrier in GBM, although blood brain barrier is little bit broken, but not as in metastasis, which there is no blood brain barrier. So that's why, like, we have this thing, like, we have these type of curves. So this can be exploited as a phenomena to see the difference between the GBM and metastasis. And now, like, if we have this question, we can also take the help of spectroscopy. We can, like, if we do spectroscopy on the enhancing lesion, we'll definitely find increase in choline and creatine. But if we do spectroscopy in the peritumoral area, then peritumoral area will not show any increase in choline in the in cases of metastasis, as we know that they are not infiltrating margins. So that this lesion is a metastasis. And if we see this lesion, like, if you see, this is the brain enhancing tumor here, and we have done the spectroscopy in the peritumoral area, and you see there is increased choline, decreased Na, decreased creatine, and increased lipid, and this is suggestive of a very high grade glioma. So choline to creatine ratio is 1.8, and so in the peritumoral area, you see here, like, in the peritumoral area. So that means, like, this is infiltrating margin tumor. So we can, by studying the peritumoral area, we can tell, like, on the perfusion or spectroscopy, we can tell that whether the margins are infiltrative or not infiltrative. So this has a very good value. I will show you, like, another examples, like how identifying tumor margins we can help with this advanced imaging. Like, this is another example, like, we have in a big tumor, enhancing tumor, and we do the spectroscopy, very high choline to creatine ratio. That means lesion is malignant. It is a homogeneous. But when you do, like, perfusion, although spectroscopy is showing it is a very high grade lesion with a very high choline to creatine ratio, but the perfusion is low. Like we saw, like, the perfusion is very low in this big enhancing tumor. So what we came out with, like, there is a restricted diffusion. Like, there is another classical finding in cases of lymphoma. So in this case, there is a, like, this tumor, although showing restricted diffusion, but increased in cerebral blood volume. So this tumor was a like high grade glioma, and indeed there was significant neoangiogenesis. And if we go here, this tumor, like, most of the people still use only diffusion weighted imaging, but I think, like, there is a role of perfusion imaging, and the perfusion imaging is showing very low perfusion. And that means what we call this phenomena is an enhancement perfusion mismatch. So in enhancement perfusion mismatch can be seen in lymphomas. And, like, this is another lesion with, like, very high choline to creatine ratio, and in lymphomas you can see a very large lipid peak. And similarly, like, and another thing, like, which we found in MR perfusion, like, if I can show you, like, the normal curve is the green curve, like it reaches the baseline. But in cases of lymphoma, what we found, that this curve overshoots the baseline. So then we have a, like, good idea, like we could differentiate, and we published it in AJNR, like, and that if there is a high recovery, it is a lymphoma. And if there is a GBM, there is a medium size recovery. If there is a metastasis, there is a very low recovery. So that way we could differentiate between the lymphoma, GBM, and metastasis. And see, like, but there is a pitfall, like, in cases of oligodendroglioma, we have to be a little bit careful because there is a increased perfusion in cases of even low grade glioma. The oligodendroglioma because of these chicken wire like vessels. Then we thought, like, what we can do to differentiate, we could do the permeability imaging, and with the permeability imaging, there we could find out that there is a low permeability in cases of low grade oligodendroglioma, and in cases of high grade oligodendroglioma, there was permeability imaging had some role. So now coming to tumor mimicking lesions. So like, that lesions, like, it's enhancing lesion. Although, like, in cases of abscess, we have, like, very low perfusion, and cases of, like, we can do spectroscopy or perfusion, like, so even in the same with the tumefactive demyelinating lesions, because there is no neoangiogenesis and there will be no increased perfusion. So the perfusion has a little bit role in the hair also, and we can see these acetate or succinate peaks in cases of abscess. So, like, another role we have, like, we can see, like, whether tumor has a low prognosis in cases of very poor prognosis in cases of high glioma, like, although non-enhancing tumor, but we see increased perfusion, then this is a poor prognosis. And another, like, as we know, this is, like, most commonly used in cases of our day-to-day practice. This is, like, like radiation necrosis versus tumor recurrence. And as we know, like, this is, like, very classic, like, I still believe in this pattern, like, that if you see the enhancing tumor, within the enhancing tumor, within this enhancing area, there will be small areas of necrosis, what is called, like, Swiss cheese pattern or soap bubble pattern, which we can see in cases of radiation necrosis. Like, if I can convince you, there is, like, this is like solid enhancement, but within this solid enhancement, there is necrosis within that. So what favors recurrence? There could be, like, then we can use spectroscopy. On spectroscopy, you can see, like, there is a very high choline to creatinine ratio in cases of high grade tumors, like in case of recurrence. So that's how, like, we have this case has a solitary brain metastasis, and there is a area of enhancement. We don't know whether it's a recurrence or whether it's a radiation necrosis. And we do the perfusion. We see the perfusion is very low. Like, we can see that this is almost equal to the normal side. And so we can say this is a radiation necrosis, predominantly radiation necrosis. Here,
Dr. Rajiv, we have another 2 minutes.
Okay, sorry. I will just quickly go about this. And, like, it's a, I have tried to give you, like, we can differentiate between progression as well as pseudo progression these days, as we know, like, with the radiation temozolomide. And we have, like, we can define tumor margins better in cases of, like, we do spectroscopy, and we can differentiate between the edema and as well as infiltrative margins. And we can, like, so that we can plan radiation better nowadays. Like, many departments are doing radiation planning with the diffusion and spectroscopy and, like, more perfusion imaging, which we can see, like, the tumor is very small, non-enhancing, but actually the tumor is very large with a good amount of cellularity in the, like, non-enhancing portion. So this is, like, relatively, and we can do DTI imaging to see the tracts, which we are, like, pre-surgical brain mapping, we can use them. And so these are, like, we can differentiate various tracts. And, like, we can do, like, functional imaging. We can do lateralization of the language or motor area, like, how far it is the tumor. Here we can see the Wernicke's area is near, but the tumor can be resected. So these type of things, like, these days, nowadays, like, I will leave it here, because radiomics and radiogenomics are the new things which are coming. Like, we are not doing it these days, but they have a very promising role. And we probably, like, in the near future, we will have, like, more and more studies coming out, which which will be integrated in our packs, and we will see that we can have more texture analysis within these brain tumors with the help of this radiomics, which are like computer-based analysis with the artificial intelligence. Thank you so much.
Thank you very much, Dr. Rajiv Mangla. Thank you for your excellent talk. It just goes to show how far neuroimaging has come through now, almost leading us to the field of molecular and genomic analysis with imaging. And it certainly would help us as physicians and surgeons to really provide the best standard of care to our patients who are suffering from brain tumors, especially gliomas. Thank you very much again, and thank you very much for your valuable time in the early hours of the Sunday morning in New York. Thank you. I will go over to our next speaker now. Dr. Hans Kovgaard Poulsen is Professor, Chief Physician, and Head of Section for Neuro Oncology and Department of Radiation Oncology at the Fincenter, Copenhagen University Hospital. He is a member of several scientific associations and clinical evaluation boards. He has extensive research experience and has authored numerous peer-reviewed articles and papers in relation to oncology and tumor biology. Dr. Hans Poulsen, thank you very much for joining us this morning at the 19th Cancer Symposium hosted by Shaukat Khanum. Over to you. Thank you.
Okay, thank you so much for inviting me to appear here at this symposium again. It's an honor for me to try to give you some of my information. My main talk will be about gliomas because that's the main task in adult neuro-oncology. We don't, as oncologists, we don't treat meningioma as much as gliomas, and what I will especially do is trying to show you data which is the basis for where we stand today. Our goal of our treatment is a very simple one, but not an easy one. It's to prolong life, and in addition to that, to increase quality of life. We have been much better in recent years to increase quality of life. But as I will show you, in some areas we have also been able to prolong life. So there are some successes that I will talk about. A number of years ago, there was a paradigm shift concerning gliomas in adults. Earlier, we thought it was a local disease with some fingers out in the brain. But I think that everybody now agree that gliomas is a systemic disease within the brain with a chunk of local tumor, but with cells all over the brain, along the vessels and along the nerve fibers. And as a consequence, 15 years ago, it became a standard to treat these patients with both local and systemic modalities. Local surgical treatment, radiation treatment, and systemic modalities, chemotherapy, and other medical therapies. In recent years, there has been a tremendous developing in molecular characterization of gliomas, which has also had some influence on the way we are treating them. If you're looking at the left side, there's a number of key features which is important to find out in a specimen if you want to try to characterize what kind of glioma are you working with, because it is important today that you standardize, that you are quite specific about the specific diagnosis, because it has some consequences when you treat them. And I don't want to go through all this, but the IDH1 status is one important thing, whether it's mutant or a wild type. The mutant is very often in the low-grade gliomas, and the wild type is very often in the glioblastomas. And then there is this alpha thalassemia mental retardation syndrome linked mutant, the nuclear RTRX, which is also an important feature to find out when you want to classify them. And then there is, of course, the 1p19q status, because if it is deleted in the tumors, you get oligodendritic gliomas. If they are not deleted, it's not an oligodendritic glioma, but some kind of astrocytoma 2 or 3 or whatever. So in the new WHO classification, they have used these molecular standards in order to help us to characterize and be more specific about the type of tumor that we are looking at. I know that that is not possible everywhere, and the WHO classification also have alternatives if you don't have these skills there. But it all ends up that you have oligodendroglioma, astrocytomas, grade 2 and 3, glioblastoma wild type, which is the normal one, and then the IDS8 mutation. And then there is this very important thing, and that is that when they have a mutant H32K27M. So a number of the tumors which were classified as grade 1 and grade 2 and 3 earlier, but they had a very bad prognosis. It looks like they have now this mutation that you have to classify them as a grade 4 and handle them like that. But just to sum up, some molecular features are important when you characterize the tumors, because it will have some treatment consequences. I'll just go through a number of trials which will be the basis of what we are actually doing to patients today. And let's start with the low-grade glioma. This is a study from New England Journal of Medicine in 2016. And, they took 2 groups, a low-risk group, less than 40 years, close total resection, observation. And then the high-risk group, subtotal resection, age over 40, they stratified by oligodominant and astrodominant. They would not do that today, because it's very clear which is oligodendroglioma, which is not an oligoglioma. But then they did the randomization, and in the one arm they gave them radiotherapy alone, and the other arm radiotherapy plus chemotherapy as an adjuvant setting with CCNU, PBZ, and vincristine. Is an old schedule which is not used very much anymore. But what you can see here, if you're looking at this slide here, If they got RT alone, that's the blue line, and RT plus PCV. After 3 years, these two curves divide, and it's quite significant that if you upfront give these tumors radiation plus chemotherapy, they do much better than if you give them radiation alone. And this is something different from the attitude we had 20 years ago, because when you had a grade 2 tumor at that time, we often did say wait and see based on some randomized studies in the 80s, where you randomize between radiation or radiation, no radiation to these patients, and it looked like they had the same survival. But they didn't give them radiation, chemotherapy at the same time, and this is the difference. So the standard treatment today in some of these tumors is to give them radiation and chemotherapy in grade 2 glioma. If you go to the anaplastic oligodendroglioma, there's two studies, major studies. There's an European study with adjuvant PCV after radiation, and then there is an American study with neoadjuvant PCV before radiation, and then they did genetic analysis. And if you're looking at, I apologize where it's a little bit small to look at, but if you look at patients with mutations and patients without mutation in the 1p19q area, if you're looking at survival, this is the European study. After 7 years, the curve divides, and if you give them radiation plus PCV, there is a tremendous difference in survival. But in the non-mutated one, which is oligos, or supposed to be oligos, with no deletion of 1p19q, there was no difference. And this study and the next study is the reason why today you define oligofeature-like tumors with no mutation as an astrocytoma and not an oligodendroglioma. So oligodendrogliomas today is only tumors with oligofeatures and 1p19q mutation. The American study, you look almost the same after a number of years. There was this difference between radiation alone and radiation plus chemotherapy survival. But it is also noteworthy that this difference did not appear before after 4 to 6 years. So that's an important lesson to learn, that you have to be patient when you do studies, because you have to wait for the final result, and not just say after 4 years there's no difference. So that's not that there's no efficacy, and that is not true. Going to the grade 3 gliomas with no 1p19q co-deletion, they were stratified between MDMC. There is this German study with radiation versus radiation plus temozolomide, or neoadjuvant treatment, no adjuvant treatment, or adjuvant treatment, so on. And so the basic question here, does it add anything to the survival if you add chemotherapy to the radiation? And what is seen in this study here, just look at the overall survival. This is percentage, and this is years out here. It's quite clear that the study shows that that if you give them give these patients radiation plus temozolomide, their survival is much better. this is also confirmed in a Scandinavian study, actually done by myself, where we randomized between radiation alone or 3 cycles of neoadjuvant temozolomide and then radiation. And what you can see here is, when you look at the survival, there is a tremendous difference in median survival if you give them radiation plus temozolomide compared to radiation alone. So this is the chemotherapy group, and this is the radiation alone group. So there is a factor 3 difference in median survival. This was grade 2 and grade 3, and then coming to the classical study from glioblastoma, where you gave these patients radiation plus concomitant temozolomide followed by 6 cycles of adjuvant temozolomide. This is Dr. Stubb, who is given the name to this study here. And what was shown was that if these patients with glioblastoma, they were treated with radiation alone, compared to radiation plus temozolomide, there was a significant better survival. Not impressive, but it is significant better survival if you give them concomitant and adjuvant temozolomide and radiation. That's the blue line. Then there was something. There was some who was responding well and some who was responding bad. And they found out that if one was looking at the O6 methyltransferase promoter, and the methylation of that, the MGMT also called, one could see that if this promoter was methylated.
Dr. Paulson, sorry to interrupt you. Kindly share your slides with us.
Huh?
We can't see your slide at the moment.
Can I see my slide?
Yeah, we can't see your slides. Prof, is it possible to come back to your talk after listening to Aisha, who is our next speaker?
Yeah.
Because there seems to be a lot of echo. Okay, thank you. Thank you, Professor Paulson, for your excellent talk. We'll carry on with our next speaker, Dr. Aisha Arshad, we are now going to digress a little bit from brain tumors and listen to her talk on the surgical fixation of metastatic spine fractures, our initial experience at Shaukat Khanum Hospital. Dr. Aisha has recently joined us as a spinal surgeon. Her initial training was in Pakistan, and she did her FCPS in neurosurgery here, and then went over to UK, where she did her spinal fellowship for 2 years, and at the University Hospital Birmingham. And certainly she has gained a lot, and she's a big asset for our team here at Shaukat Khanum Hospital. Dr. Aisha, thank you very much for being with us here today. Please carry on with your talk. Thank you.
Thank you for being so kind, Dr. Irfan. Bismillahirrahmanirrahim. My name is Aisha Arshad. I'm the senior instructor working as a spine surgeon at Shaukat Khanum Hospital, Lahore. And thank you all of you for joining us at the 19th Shaukat Khanum Memorial Hospital Cancer Symposium. And I feel honored to be a part of it. Today, I shall be talking about the surgical fixation of metastatic spine fractures, our initial 1-year experience at a cancer hospital from a developing country. So when we talk about metastatic spinal fractures, they might not be very common as compared to brain tumors, but they become significantly common enough when you see the them from the perspective that they occur in about 1/3 of the cancer patients at some stage of their disease and at some stage of their life. These are all slides showing metastatic spine fractures in the lumbar spine, then the thoracic spine, then the cervical spine. So they have, although metastatic spine fractures have been in the picture ever since we have been treating cancers, and they have increased in frequency with the increase in survival of cancer patients, but surgical fixation for these fractures is still a relatively new concept. This has gained popularity over the last 2 decades, and the reason for it coming in vogue and remaining in vogue stays that these procedures enables these cancer patients to live their remaining days with dignity. That is what I always feel, that they prevent neurological deterioration, they preserve spinal stability and functionality of the patient, and they can live their days with dignity maintained by the patient as well as by the family and the caregivers. Therefore, this procedure has now become part and parcel of the standard of care for cancer patients all over the world, especially in the developed world, and is considered to be a highly efficient and resource effective means of treatment for these patients. However, when we come to the developing regions like in Pakistan, we are still very limited in our resources, and our oncological service has become a part and parcel of all cancer treatment modalities. Uh, this field of surgical fixation for metastatic spine fracture, it is still lesser developed in Pakistan than one would like it to be. But having said that, the oncological services in Pakistan are still not very developed. Actually, Shaukat Khanum is the cancer hospital in the country at the moment, catering to a wide variety of cancer treatment modalities, not happening anywhere else in the country. So keeping that background in mind, when I came back from my fellowship in UK last year, I came back in October, and I started working at Shaukat Khanum Memorial Hospital and Research Center. I had it in my mind that we wanted to start the spine oncology services. Although spine surgeries were being done here, but we wanted to establish this as a proper service, and we wanted to be more frequent and more available in this regard. Whenever you start a new service somewhere, there are a lot of challenges faced. And I had a lot of them in my mind when I came here and I joined here. And I'm sure at least some of you will understand that developing a service in a developing country can be even more difficult than developing one in a developed country. So we faced the challenges including equipment. We did not have proper spine equipment needed for modern spinal surgeries. We are trying to get that even now at the moment. We have some equipment now. Then COVID happened, something that has even paralyzed the developed nations. So what to talk about in countries like Pakistan. So that has slowed down us a lot. Then, like I said, since we were not doing spinal surgeries very frequently before that, we were wanting in terms of trained theater staff for conducting spinal surgeries or assisting spinal surgeries. And of course, the post-op care of these patients, including physiotherapy, rehabilitation, and of course, immediate post-op care as well. Having said that, I think it would be only fair to mention that I had a great supportive team. I would like to take the opportunity to name a few. From the administration led by Dr. Asim Yusuf and Dr. Asif Loya, I had two most prestigious supervisors in form of Dr. Irfan Yusuf and Dr. Kamran Hussain, who were everybody down to my theater staff, OTAs like Arif and nursing technicians like Shazia. They have been more than helpful in, and we have done so many new procedures, which I understand are difficult for them to cope up with. We have to ask for a lot of things, but every single time I feel that we welcome change, which is really what we need to establish any new service. I've always had support from everyone, and I've always had a welcoming gesture from everyone whenever we have tried to do something new, which is actually what made all of this possible. So we just wanted to analyze our data initial fixations that we did, and this is a retrospective analysis of the patients undergoing surgical fixation for metastatic spine fractures at the Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore, with regards to their demographic characteristics, treatment, and complications. What we wanted to do is we wanted to see our learning curve as an institution. Of course, we are trying to develop a service. As a surgeon, I would always like to love being still in a learning curve, because it automatically means I'm going up. Flattening a curve might be a good idea for COVID-19, might not be a good idea for surgeons like me, because we always need to feel that we are going up, becoming better. And of course, we wanted to do a services audit. So study in design, it is a retrospective observational study. It was done in the Department of Surgical Oncology, where I'm working at Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore, for a duration of 12 months on the 1st of November 2019 to the 31st of October 2020. I started at Shaukat Khanum around mid-October last year. We had to get all the equipment and got a bit late starting, but I think we are now increasing in our frequency. So COVID took about 4 months from us, I think, when we had to stop our elective lists. But we'll talk about that. I still think we have a good enough sample size, and our sampling technique was consecutive sampling. Inclusion criteria was all patients presenting with metastatic spinal fractures at Shaukat Khanum Memorial Cancer Hospital and Research Center during the above period and undergoing surgical fixation. Exclusion criteria was all other patients that were not fixed surgically and were managed conservatively, patients deemed fit for surgery or were offered surgery, but the patient refused surgery, and of course the patients who were deemed unfit for surgery. A questionnaire was used to retrospectively collect data from hospital records. The data was entered and analyzed using the SPSS-20 system. And then we got some results. So in this period, we did surgical fixation of about 14 patients with metastatic spine fractures. Of these, we can see in gender distribution, majority of them were females. I think because we'll discuss in the later details that a majority of them had breast cancer, and breast cancer is prevalent in females. The age range is from 24 to 64 years. We can see from the graph that most of these patients fall between like 40 to 50 years. Regarding comorbids, we try not to operate on patients with a lot of comorbids, as any spinal surgeon would do. Most of you would know that. So only 4 patients had hypertension. Most of the, about 3/4 of the patient did not have any comorbids. Regarding presenting symptoms, so all of these patients presented with back pain or neck pain, and 10 of them had neuralgia, that is shooting pain along nerve distribution, and about 9 had some form of neurological deficit. Regarding primary malignancy, where does the metastasis come from? In 50% of the patients, it came from the breast. In 2 patients each, it came from the parotid or the esophagus. There were other sites as well, which are less common in 3 of the patients. We wanted to see how much time had passed between the initial diagnosis of the primary malignancy and the patient developing spinal metastasis. And this is our data, that we can see that about 3/4 of the patients presented 1 year or more after the initial diagnosis of the primary malignancy. Only 1 patient presented 6 to 12 months, and 2 patients presented less than 6 months after primary diagnosis. We will talk a bit more about these 2 patients later today. So, taking from there, most of the patients had surgery and oncological treatment for the primary disease before they presented with spinal metastasis. The important thing to note here is that 2 of these patients were operated without any prior treatment for the primary malignancy. And like I said, we'll talk about them in a bit more detail later today. So in all patients presenting with any metastatic fracture in the spine, we get an MRI whole spine with contrast to see the disease burden in the spine. And when we did that, we found that half of them had disease in the lumbosacral spine. About 6 patients had disease in the thoracic spine. Only 1 patient had cervical metastatic fracture that got fixed. Then the extent of spinal involvement, how many levels were involved? Most 2/3 of the patients had single level disease. Then the systemic disease burden, another important factor. And as expected, we can see that 2/3 of the patient did not have any systemic metastasis. The other patients had had a single metastasis in the liver, lung, or pancreas or mediastinum, but their prognosis was deemed to be more than 3 to 6 months by the treating oncologist. Therefore, they were offered surgery. As far then the third parameter is of course the performance status of the patients, and we can see that about 3/4 of our patients were ambulatory at the time of surgery. Only 4 patients were not ambulatory when they had surgery or when they presented to us with spinal metastasis. So what did we do for these patients? The procedure that we have been following is decompression of the cord at the cord compression level and fixation of the spine for stabilization. The length of fixation varies from case to case. Of course, I'm sure all spine surgeons will understand that. It has been, in our case, about 1/3 of the patient got a spinal fixation from 5 to 7 levels. Most of the patients had fixations up to 5 levels. Then length of stay. Length of stay is important because if you are, especially when you're starting a service and when you want to prove that it is cost effective and resource efficient, you don't want patients to lie in the hospital for a very long time. Therefore, we wanted to see how much our patients were staying extra in the hospital because of this procedure. So our mean length of stay is like 5.14 days, and we can easily see that most of our patients get discharged by 4th day or 5th day of surgery. When we see the outcome, we use the Frankel grading score, and I wanted to see the outcome at discharge preoperatively, the Frankel gradings, and then we can see that preoperatively, C means that they were not independently ambulating or independently functioning with or without support. So we can see that 2 of our patients were not ambulating with or without support before surgery. However, at the time of discharge, all of these patients were ambulatory. All of these patients were performing daily life functions with or without support. Later on at 1 month, one of these patients did develop neurological deficit, and unfortunately he developed a wound infection and became paraplegic, and that never recovered. However, the rest of our patients remain functionally stable. The reason for the number of patients being less at 1 month and then even less at 3 months is that, if you remember, the duration of the study is until 31st of October 2020. That's 1 week from now. So the follow-up ranges from 7 days to 3 months. So all the patients were not followed up for 3 months because, like I said, the study recruited patients until 31st October. We wanted it to be a 1-year study. Then we only developed 1 complication of wound infection, and like I said, that patient developed paraplegia. So we can conclude that surgery for spinal metastasis is a safe and viable option for patients with metastatic spine fractures, and good results can be obtained in resource-limited countries like Pakistan. Surgery for spinal metastasis can be used for a number of indications, and it would be just fair to mention this landmark study done by Patchett et al. In 2005, which showed that this has a survival benefit and this improves neurological status of the patients and functionality later on. Lately, some other research works has been done. I am getting short of time, so I'll just skip through that. So our limitations include that it was a retrospective single center audit, developing field with resource limitations, but we are looking forward to newer and modern techniques, which we have, some of which we have started, like minimally invasive surgery and separation surgery. SBRT in spine, we are looking forward to starting very soon. So if you have any questions, I'd like to answer them. This is just a slide showing some of my handiwork. Just like this slide, it's not perfect, but I do hope that we are getting there as a team. Thank you.
Thank you, Dr. Aisha, for your excellent talk. Certainly, it's a good start for what appears to be a very complex field. And we have patients who are really very unwell and have metastatic disease, have gone through a lot in terms of chemo and radiation therapy for their primary oncologic diagnosis. And we are trying to help them out by improving their quality of life towards the very end of their treatment. Thank you very much again. Certainly, we have tried to make sure that patients do not run into complications post-surgery, which can actually be counterproductive for their future survival. Thank you again. I think we'll try to connect again with Professor Paulson and take questions at the end of the session. Certainly, you have another go in terms of case discussions for spinal tumors. Thank you very much again. So we'll try to connect again with Professor Paulson.
Can you see? You cannot see it yet? No.
Not yet. Your presentation is still not visible.
I don't think it's possible then.
Okay.
Because I am not the most technical guy here in this world, and I don't know how to do anything here.
Sure.
If it doesn't come, huh?
It's okay. Would it be okay to take a few questions?
Yeah.
Okay. So, thank you for your excellent talk. And I've always wondered, we have a good tool in terms of radiation and chemotherapy for oligos.
Yeah.
But for astrocytomas, especially grade 2, and in our part of the world, the presentation is actually very late. The tumors are really very large, up to 5 centimeters and beyond, and we have incomplete resections. For these kind of patients who actually fall into the high-risk group, is the standard of care just radiation, or would you recommend radiation plus chemotherapy, especially for grade 2?
If you have these diffuse low-grade gliomas, it has been the standard before either to wait and see or to give them radiation. But there is this study from 2017 or 18, which were published there, where they gave them upfront radiation and temozolomide, and it appears to be better than give them radiation alone. So that's why we follow that, and that has also been other studies about that, and I cannot explain why it is so, because earlier we just did like many others to wait and see, but it appears that if you want to be on the beach, so to speak, you have to give the radiation and temozolomide at the same time. And there is a tremendous difference in survival, actually. That's the main point. But it takes a number of years to do that. There's also been talking about the low-grade gliomas because they live longer than the glioblastomas, where one should try to avoid radiation and then give them temozolomide instead of because of late toxicity. But there is now a study from Germany where they have just stopped this arm giving temozolomide alone because it's less effective than the combination. So what they do now is that they don't give that anymore. So, but it is low-grade glioma is a very difficult task actually, and also because whatever you do with your treatment, it will have long-term effects. And there is another study from France where they have given temozolomide alone, and this study is not finished, also a randomized study. So I will not be the guy who is telling you have to do so and so, but there is data that appears that this would be more optimal than just giving them one modality alone. So that's why.
Thank you very much, Prof. Thank you. So if there are no further questions, I'll move on to the next presentation by Dr. Aisha again. This time she's going to share some cases of spinal tumors. Certainly these are rare tumors, but because of the significant deficits that tumors can cause, we may have to remove them surgically. And at times there's very little option in terms of providing chemo or radiation. Dr. Aisha, thank you very much.
Yes. So welcome again, all of you. And what we are going to do now is that Bismillahirrahmanirrahim, and we are going to discuss a few cases. These are spinal cases that we operated on in the last year. Being the cancer hospital in the country, Shaukat Khanum Hospital does attract a few of those cases that you will not see a lot of in other places. So we have just selected a few interesting cases for discussion today, and I would like all the panel to participate in the discussion. If you can all please share your screens and share your videos, and let's start this discussion. So these are all spinal cases, but they're all spine oncology cases. So I'm sure we'll welcome input from oncologists and radiologists as well. So we have some interesting presentations of thoracolumbosacral ependymoma to discuss first. Case 1 and 2 are similar. I've just put them together on one slide. Both are ladies. Both are around 29-30 years old. Both presented initially with lower back pain. Initially, there was no neurological deficit, and they have both been carrying their disease for 6 months. I'll explain the reasons. In the first case, this lady presented with lower back pain and progressive some numbness, some paresthesias. At that time, she had an MRI done, and that MRI showed a huge T11 to S3 intradural space occupying lesion. Typically, radiologically, myxopapillary ependymoma. She was offered surgery, but she wanted to go for some other forms of treatment. Sometimes more than we would like to admit, our patients do opt to trust other people over spinal surgeons. However, so her surgery got delayed. She refused surgery initially, and her surgery got delayed because of that. About 6 months down the line, she came again, and at that time, she was having weakness and significant issues with mobility. Now that she had developed weakness in the lower limbs, she was more compliant to have surgery. So we did her surgery on her. Then in the second case, the 29 years old lady, this unfortunate lady presented with back pain and bilateral leg pain. Her pain was so severe that she was actually agreeing to have surgery initially, but she got delayed because of COVID, because our elective list got cancelled. She did not have any neurological deficit. So later on when she came, she again had, fortunately, no neurological deficit, only back pain and leg pain. This was the MRI. So we can see it's a very long segment disease. My interest, when I saw the scan initially, I remember I got excited. And my interest in this scan was, if we can operate on her now, there is no neurological deficit, so that's not an indication for surgery. But if we can operate on her now, we can get rid of the entire tumor before it goes into the sacral canal, because then it will be difficult to get rid of it all. So that was my interest. And then she might be cured for life. So we operated on her, and fortunately, we got rid of the tumor. One interesting fact in this is, before I say, what does, I'd like to ask our radiologist colleague, what does it look like? And because I'm asking, it's not the typical thing.
I see. So, like, yeah, if I have to read this one, like, I would say,
yeah.
This is I believe these are contrast enhanced imaging.
Yeah.
And we see the tumor, like, which is like, causing expansion of the canal. Like, so it seems like it's a relatively low grade tumor. And like, in my experience, like, although the tumor, the differentials can be like, can include ganglioglioma or like, but I would still prefer that it's, or like, very rarely pilocytic astrocytoma, but I would still prefer myxopapillary ependymoma above over other differential diagnosis.
Yeah, that's what we thought also. It's close. It's still close. It just came out to be ependymoma grade 2.
Okay.
That came out as a surprise because it was not grade 1. That was the only thing. So it just came out as grade 2, and this is the post-op scan. So the tumor, this is gross total resection, and I think what our MTT decided. Do you want me to tell you that, or Professor, do you want to have a go? Do you think it needs further treatment, or shall we just wait and watch? It's grade 2.
Am I the professor?
Ependymoma.
Am I the professor?
Yeah.
Okay. I think what we do is to try to operate these patients, and then because radiation and chemotherapy is not a very good task on epidendymoma, so we try to be quite conservative in order to give them this treatment. Also because when you treat there, and if you don't have proton treatment, you have a big chunk of the normal tissue that you have to include in your radiation field, and that and they are living for a good length of time, and then they can have severe side effects.
Yeah.
But if we would have to treat a patient like that, we have our proton facilities. We've used that, but
Okay.
it's not. But with normal radiation, I would try to stay away.
Okay. So that's what we have done. We are just keeping her on wait and watch. Hopefully she will escape any further oncological treatment. So this is the third case, and this is actually quite an interesting case. A 15 years old gentleman, he presented with lower back pain and progressive paraparesis. Again, for like about 6 to 8 months. What happened in this case was that this poor boy, he belongs to a rural area. It took him a while to get to a spine surgeon. By that time, he was almost paraplegic. So he was operated initially by a spine surgeon outside Shaukat Khanum hospital. When he came to our hospital, it was basically according to the patient, it was for post-op radiotherapy and chemotherapy. However, when we did the MRI spine on the patient for oncological planning, this is what we saw. So we can see that there are two lesions basically. There's one lesion in the thoracolumbar spine, and there's another lesion in the lumbosacral area. So we can see that these are the two lesions. This is in the thoracolumbar spine. This is in the lumbosacral spine. We can see laminectomy changes. We can appreciate that somebody has done posterior decompression and laminectomy and possible partial resection or biopsy of this lesion. However, there are some, we can also see that this is only partial debulking or biopsy. This is not complete removal. And this is something interesting, that the cord has herniated out through the defect, and there is a sharp kink in the cord. Then we can see another lesion in the lumbosacral region from L4 down to S2 or S3. And in between these two lesions, we can see this sliver of contrast enhancement. These are contrast enhanced images. So 2 or 3 interesting facts in this MRI. You can see two lesions. You can see a connection between them, which you can say like sugar coating of the dura, or maybe these are drop metastasis. The histopathology from the first surgery, by the way, came out to be myxopapillary ependymoma. Myxopapillary ependymoma with, now we have the diagnosis of myxopapillary ependymoma with drop metastasis, sugar coating of the dura, another lesion in the lumbosacral area, so concomitant to lesion, and spinal cord herniation with a sharp kink. The patient said that his paraparesis had improved slightly after the first surgery, but he still was wheelchair bound, and the power in the leg was maximum 2/5, not more than that. So what are our thoughts at the moment? What do you think we should do?
You have the right diagnosis. You're sure about that?
Yes. Yeah. Yes, we have the right diagnosis because it came out. Yeah.
Are you able to operate now?
Yes.
You are?
Okay.
Can you operate this patient?
Yes.
Yes, Professor Paulson, may
Yes,
I
please.
pitch in? You know, I don't have a big interest in spine surgery, but when we saw the spinal herniation and the fact that the patient had really not improved
Yeah,
after the first surgery, uh, we were actually, my own feeling was to go ahead and operate again. We
yeah,
had the diagnosis mixopapillary,
yeah,
um,
definitely.
it's a low grade.
Yeah.
Could we actually help the patient by doing a further debulking, trying to correct the herniation, and as well as see if we can have another go and remove further components of the tumor if at all possible.
I
And
think
you know,
doing this further surgery is a better option than try to do radiation, actually.
sure. And you
But
know,
you never know where it's gonna function or not.
yeah, and in terms of preserving function for these tumors, which are quite extensive, we don't at the moment have the facility for neuromonitoring to actually monitor the spinal function in terms of motor function, sensory function, and sphincter
Okay.
function. So that was a little drawback, which can become quite significant in these patients, where we have to preserve function, and we know we are at the end of the day dealing with just a grade 1 tumor. Over to Aisha. Thank you.
But in terms of trying to speculate where there is a drop metastasis, you know, epidendymoma is known for having drop metastasis, so that's a very good reasoning, actually. I think so.
Yeah. So what we discussed in the MDT, and like Dr. Irfan said, we opted for surgery. The plan for surgery was to try to remove both of these lesions, and we cannot do anything about the sugar coating, but at least try to remove both these lesions and decompress, and then we'll see where the patient stands. The patient was brave enough to opt for the second surgery. I must give him that. He's a charming boy. He said, I will go for the second surgery, although all risks were discussed in detail. We were not hoping for a meaningful neurological recovery because of the prolonged duration of the deficit. Uh, then we went in for surgery. We decompressed the spinal herniation. Professor Kamran Hussain was with me, and we decided not to go for the dissection of this tumor, the thoracolumbar one, because like Dr. Irfan said, we don't have neuromonitoring, and it might have caused more damage than harm. Everything was completely fixed. Everything was fibrosed. The dura was, it was very difficult to find a plane between the dura and the tumor, or the dura and the cord. So let alone the plane between the tumor and the cord. So, however, we did try to resect the lumbosacral component, and this is what we got post-operatively. So we can see there is a sizable reduction in the size of the lumbosacral component. The herniation has been decompressed. There is no sharp kink there. Neurologically, the patient improved miraculously. And the last time I saw him, he was voiding normally, passing urine and stool normally. He is ambulating now with support. So that's one of
Yeah,
the good things that
but
came out.
just to follow up on that, you know, we were talking about radiation after that, maybe, but I don't think it's a good option. You know, chemotherapy in epidendymoma is a very bad story. We have no effective chemotherapy in epidendymoma. So I
Right.
would never suggest chemotherapy to that kind of patients, even if there is some rescue.
So I would just like to mention here, I myself, having started just last year, this is a very interesting case, and for me, it was my first time seeing this type of case. But Dr. Irfan and Dr. Kamran, and I have seen a few of them now, and I've done a few of them now. Dr. Irfan and Dr. Kamran have been totally supportive throughout, and they have kind of like supported me when I stand operating. They actually, I think I can sometimes I can stand in the theater because they both of them have my back, and that's the only reason I can stand and operate. I remember one of my senior colleagues in UK saying that exactly same thing, that my supervisors have pushed me to do things even when I'm not comfortable, even beyond my comfort zone, because nothing grows in the comfort zone. So I'd just like to say that cases like these actually do help, and seniors like Dr. Irfan and Dr. Kamran actually help a lot. So this is another case, two cases in which the patient was treatment naive, no chemotherapy, no radiotherapy, and we had to spine metastasis on our hands. And of course, then we operated. So just interesting enough to present, 37 years old lady, young lady with a young boy and married. She presented with low back pain for 2 months. The only history she had was an axion of mesenchymal chondrosarcoma of the upper limb about a year back. No other comorbids. The MRI spine was done because of the lower back pain, and it showed this picture. So I would like the panel to comment on this. Dr. Irfan, are you there? So
Yeah.
Dr. Irfan, can you comment? So this is the picture that we saw. This is T12 metastatic fracture with epidural component, and I remember you seeing it with me. Dr. Irfan, you're mute.
So, we debated as to how well this patient may respond to chemo radiation. And we really, from the oncologist point of view, we were told that this patient is not the tumor is not very radiosensitive or chemosensitive. And the mainstay of treatment would be to stabilize this lesion and at the same time get a biopsy as well to confirm the diagnosis.
Yeah, and another thing is that like Dr. Irfan said, the biopsy was not done yet. So we were not sure of the diagnosis. We were not sure of the primary. So another twist in the story, when we did a CT-TAP just to see if there are any other lesions, we found that there was a hypodense lesion in the pancreas, bearing 13 into 9 millimeters. It was in the body of the pancreas. So, and the report by the consultant radiologist mentioned that the possibility of primary pancreatic lesion could not be excluded. So that was a twist in the story. And then we had to take it up from there. And then Dr. Irfan, if you remember, we tried to get the biopsy of the pancreatic lesion.
Yes. I can't remember it offhand at the moment.
Yeah, I remember it was Dr. Irfan, because I still remember Dr. Irfan going to the family again and again that now this has happened and now this has happened. So now we are in the process of trying to exclude if he has CA pancreas, which has metastasized to the spine. And meanwhile, we are trying to ascertain which lesion is the best one to get biopsied and which one to biopsy. So this is the lesion in the pancreas. So however, during workup, another a marked twist in that story happened. Developed difficulty walking, increasing weakness, numbness in legs for 1 day. So Dr. Irfan.
I think that just indicated we have to go in and operate and then take it from there.
So we did posterior decompression and fixation of the spine. We did posterolateral decompression. We biopsied the lesion. It came out as mesenchymal chondrosarcoma. So we knew that we were dealing with metastatic mesenchymal chondrosarcoma. So any views about further management of this patient?
Have you used any chemotherapy to this patient?
Yes, she has been referred to the oncologist. She's on chemotherapy at the moment. The disease is stable up till now.
No radiation. No radiation.
She has received fractionated radiotherapy, not SR, SBRT or anything.
Then you're on the right side actually, because chondrosarcoma, you should try to use chemotherapy and radiation in combination with surgery, and then do the follow-up and see what's happening.
Okay, so
because you might expect that they have a systemic disease. Actually.
Yeah.
It's good.
So at the moment, her disease is stable. The pancreatic lesion is partially calcified by now. Her T12 lesion is stable at the moment. She's still walking. She's walking and she does not have any neurological deficit. So I think we are almost 1 year down the line. So that's her follow-up for now.
How big is the lesion in the stomach?
In the pancreas, it's 13 into 9 millimeters.
Okay. You know, we have surgeons in our institutions which are very aggressive, actually.
Yeah.
When you have a local control on your spine and you can't find it, very often they'll try to go in and operate these patients.
Yeah. Our oncologists, we discussed this point with our oncologists, but the disease seemed to be very aggressive at that point because it has recurred and at 2 sites. It had come from the upper limb and it was now in the pancreas and in T12. So the oncologist point of view was
in
very
recent
aggressive.
years, metastatic surgery has been much more aggressive than it was before. And
Yeah,
whatever the result is, I don't know really. Do you know, Dr. Bishop?
This is the first time, I've come across the metastases from mesenchymal chondrosarcoma. And even at our MDT discussion, the initial feeling was, could this be another primary rather than metastases?
Yeah, you have 2 primaries actually.
Yeah. So this came as a surprise for the oncologists as well, who have seen this as a very rare chance for a mesenchymal chondrosarcoma to actually metastasize to bone. So certainly this is a difficult case to go ahead with.
You know, in the pancreas, have you tried to put a needle in it to see what it is?
Not yet, no.
Wouldn't that be interesting where there's two primaries actually?
Yeah.
Because you have control here now.
Yeah.
And if you have one lesion in the pancreas,
right,
might be possible also to operate there.
Sure. Yeah. I think we'll follow on that.
Yeah, just to find out what it is actually, because as you're saying, why should a chondrosarcoma come from a pancreas?
Yeah.
Okay. Yeah.
Thank you.
Okay.
So this is another interesting case. A 25 years old lady, no comorbid, presented with a big mass in the left breast and some neck pain for 2 months. The biopsy of the left breast mass showed that it is a left breast IDC grade 2 ER80 PR30 HER2 negative. Because of the neck pain, she got an MRI spine and the CT-TAP for metastatic workup before starting her treatment. Both of them showed a compression fracture of C7 with epidural component. She also had some mediastinal metastatic lymph nodes and bilateral axillary lymph adenopathy. She was discussed in the breast MDT, and their recommendation was systemic palliative treatment and refer to neurosurgery for deciding about the spinal metastasis. So the question here would be what to do for the spinal metastasis at the moment. The patient has not received any treatment, Dr. Irfan.
Yeah, we are starting here with a very extensive disease, CA breast with mets to bone, bilateral axillary nodes are positive. And, our major guideline is from the oncologists. And certainly the treatment for carcinoma breast is quite advanced. And multiple chemotherapy regimens are now available even for metastatic disease. And here we were in a situation where there was impending cord compression and a real chance for the patient to deteriorate markedly in case the compression fracture progresses and nips the spinal cord. So on balance, as a surgeon, we decided to go ahead with fixation to stabilize the spine and then allow the oncology team to go ahead with the treatment and see how well the patient responds to that. And the reason we actually went to operate was to ensure that the patient remains neurologically intact and retains her performance status through the course of her chemotherapy and further treatment.
I guess this patient gets both chemotherapy and anti-estrogen, isn't that right? Because she's estrogen receptor positive, a very highly estrogen receptor positive.
Yes,
There was more than 80%, as I recall, that
that's right.
estrogen was positive tumor cells. But would you do when you do this decompensation there at the spine? Would you add some local radiation also, or what? No.
We usually do. The patient does receive either pre-operatively or post-operatively, they do receive radiotherapy for metastatic fractures.
Was
This
that a
patient
question?
received radiotherapy.
But well, you know, I'm not a specialist on breast cancer, but I think that the chemotherapy right now is so efficient. And also with the anti-estrogen, I'm not sure that they routinely in our institution would give them radiation, but they would try to
Okay.
decompress
Mhm.
the lesion and then go further with the with the systemic treatment. I think so.
Mhm. Actually, for this patient, the interesting fact was that she had no neurological deficit,
Well,
and the only reason to operate, she was operated as an emergency. The only emergency being that the oncologist wanted to start chemotherapy in 2 weeks' time. They did not want to delay it after that, and they said, "Do it now, or we'll start chemotherapy." And then, but
don't
they
you think
wanted to do it. But they wanted us to do it.
if
They
you
did
have a
not.
lesion which appears to be able to compress the areas around it, wouldn't you do it up front instead of waiting to see? Because you never know when
Yeah, yeah, yeah.
she's gonna be
That's
paralyzed.
that's exactly what the
Yeah,
oncologist said. So
yeah,
we went ahead and did it as an emergency case.
yeah, because it could go from here.
So because of the disease burden, the patient had some problems perioperatively. She went into acute kidney. She developed acute kidney injury because of hypercalcemia that was secondary to the osseous mets. However, we have nephrology services and that recovered. She has already been started on chemotherapy 2 weeks after surgery. At the moment, she is ECOG 0 and no neurological deficits. So
Fantastic.
this is the post-op X-ray. It was a cervicothoracic fixation with C6-7 decompression laminectomy.
And she's doing well.
Yeah, she's ECOG
Yeah,
0 at the moment. The wound
yeah,
healed very well. So let's see. She's on
fantastic.
chemotherapy at the moment. So case 6, this is a 50 years old lady, no comorbids, presented with back pain and progressive paraparesis for 6 months. I think this one is Dr. Irfan that got delayed because of COVID,
That's
because they
right.
came from Azad Kashmir. It's quite far from here. So they got delayed because of the travel restrictions imposed by COVID. So when the travel restrictions were lifted, they were able to come here eventually. So the MRI showed T4 to T10. There was a lesion in the MRI, this one. The initial MRI that they carried with them, unfortunately, we don't have that because the patient has gone back to Azad Kashmir and could not be contacted. It did not show an expansile lesion in the spine. It just showed a spot. And the MDT felt that it might not be a tumor. It might be a spot for something else like multiple sclerosis or some other neurological process going on. So they asked for MRI whole spine and brain. This is the MRI brain. And they also asked for CT-TAP just to exclude any other problems going on. The CT-TAP showed right pleural effusion, some nodules in the right lung, in the left lung, and multiple cysts. However, in the MDT discussion, it was pointed out it might be pulmonary embolism, which was confirmed 3 weeks later on CTPA, and the patient was started on anticoagulation. So meanwhile, her neurology deteriorated. And at that time, we got this scan. This is the one which we got in our hospital. This was the scan picture, and her neurology deteriorated. So her power was in the legs dropped to 1/5, I think. So what
That's
do
right.
you think, Dr. Ifan?
So, we discussed, this was a patient who had deteriorated quite rapidly. And we looked at the scan, discussed the case in the MDT, and felt that unlike an ependymoma, which has a long course, so does mixed papillary. This was something which was really aggressive. And we were thinking in terms of even a high-grade glioma or tumefactive multiple sclerosis, which is actually quite rare in Pakistan. But there were some findings in the CT chest abdomen pelvis, which also suggested that could this be a rare case of a metastasis? And Aisha, if you could kind of go back to the MR brain, we were looking at a little flare change in the right occipital area with the corresponding area of enhancement, which was really very small. And this was again pointing to maybe a metastatic process rather than a primary lesion. But the lesion in the spinal cord was actually quite large, which was very unusual. We went ahead for the spine surgery anyway, because of the rapid deterioration, to decompress the cord and see if you can excise the lesion or actually take a biopsy and see what it is and plan the treatment based on that. Dr. Anshan.
So we did surgery, we did decompression and excision biopsy. Intraoperatively, for intramedullary lesions, we usually look for intraoperative margins. In this case, they were not very clear. Intraoperative frozen section was sent because of all our doubts preoperatively, like Dr. Irfan mentioned. He was with me in the surgery. And the result came out that it is definitely tumor, but definitely it is not an ependymoma. So we closed the patient, waited for the histopathology, restarted the anticoagulation, and just wanting to mention that again, this was an emergency surgery. She came during COVID, and we operated on her on emergency list because she was deteriorating rapidly. We had to put in an IVC filter. We just had to wait for that, and then we went in. The anticoagulation was started after chemotherapy. After surgery. Histopathology came about 10 days later, showing that this is metastasis, and this is likely from the lungs. So again, it was unexpected, and we again went back to the MDT, discussed everything. So we gave her palliative radiotherapy to the spine, and she was given some chemotherapy for the lung. Unfortunately, the patient did not recover from her paraplegia. So she is paraplegic at the moment. And because of the functional status, I think we cannot offer a lot of aggressive oncological treatment. That's the last I heard from the oncologist.
It was a non-small cell lung cancer.
Non-small cell lung cancer.
Well, non-small cell. But she's deteriorating now, so there's nothing else to do. Isn't that right?
Yeah.
That's right. Her performance status is not good. And,
No.
Of course, she's on anticoagulation and also has a filter in situ for her PE, pulmonary embolism. So not a very good candidate for further aggressive treatment.
The doctor should keep away. That's better.
That's right.
Yeah.
Very interesting.
Yeah. So Dr. Irfan, I think these are all.
Thank you very much, Aisha, for your excellent presentations. And there were quite a few interesting cases discussed on this forum. We now have a few minutes for questions and answers. And I will request the audience to kindly put the questions forward. While we're waiting for that, my question to Dr. Mangla is regarding biopsies of brain tumors. At times we have had difficulty in actually hitting the exact target, especially for very large tumors where there could be areas, as you mentioned, of high perfusion or enhancement, which are actually downgrading the tumor to a very aggressive level to grade stage 3 or 4. So at your institution, are there any, is there a practice to target areas of high perfusion that you have picked up in your scans?
Indeed, there are number of papers which has discussed this thing. And even like, people have done, like the neurosurgeons have done biopsies like this, and even have done like, direct correlation with the imaging findings like perfusion, spectroscopy with the histopathological findings of cellular density, even like, molecular markers. But in routine practice, like they are like, our surgeons has never asked for it, but we can actually demonstrate very much heterogeneity on all the imaging findings, like, spectroscopy as well as perfusion imaging. And it is very much possible, like it is not very hard to find it out, like, means like it's very simple to find out, like, the areas of very high perfusion or high choline to creatine ratio. It is not that difficult, like, but as far as like, most of the surgeons, like, they go for enhancing area, and most of the time, like, it is not like, it doesn't disappoint them, like, most of the time.
Thank you very much. My question to Professor Paulson, in terms of diagnostic radiology, we are steadily improving our analysis to a point where we are trying to analyze tumors up to the genomics and the molecular level. At this stage, is it possible for you to base your treatment on the findings that we have on radiology, as Dr. Rajiv Mangla mentioned? If there's high perfusion, the tumor is high grade, or do we still have to depend on the actual histopathology to devise a treatment plan?
Well, basically, I'm not a big believer of non-invasive diagnosis at the moment, because I don't think the things we have right now is good enough, because then I think we still have to do the old way to go in and see what kind of tumor it is, because I don't think there is any good data that we can correlate or be sure that if we look at a tumor like that, and then we have some whatever DNA analysis, that is good enough. So for me, you should go in and have a right diagnosis, because you never know what it is actually. Is it a primary or is it a secondary? What kind of primary is it, and so on. So I'm not a big believer of non-invasive diagnostics.
Right. Well, I hope that
maybe I'm too old actually.
Well, I think we're getting to a point where eventually we might be converted to, depending on the non-invasive analysis of tumors. And I hope we get there. And I'm thinking in terms of very deep-seated tumors, which are periventricular, next to the thalamus, midbrain, which at times are very difficult to target. I would like to get Dr. Rajiv Mangla's comments on that. What is your take in terms of imaging these deep-seated tumors?
So I agree with Dr. Paulson, like the standard of care so far is the invasive diagnosis. And as you mentioned, like, particularly these tumors, like, which are deep-seated. And like, when we go to these MDT meetings, like, and we have perfusion imaging or MR spectroscopy, and like, and even the biopsy comes grade 2 or grade, like, they like, particularly now, there are like, more molecular diagnosis. You can upgrade the tumor on the basis of IDH negativity or IDH positivity. But many times, like, on the basis of this perfusion imaging and like, or MR spectroscopy, the oncologist has upgraded the tumor based on like, because biopsy has been done from a like, area like which is probably not, and if the radiological features are more in favor of means like a higher grade tumor. So there has been a discussion, and many times, depending on our radiological findings, tumor has been upgraded and has been treated aggressively.
I also think there is another thing, and that is that there's still a big place for surgeons in brain tumors. If you have grade 2 tumors, you know, there is these studies showing that if you're very radical in your surgery, it goes better. If you are very radical in glioblastoma, it also goes better. There is a tremendous place still for surgeons in this specialty. So I think that one has to be careful just to look at pictures and look at genes. Actually, I don't think we are there right now.
Sure. Okay, thank you very much. There's a question from the audience for Professor Paulson. The question is, there is a mixed opinion on extended temozolomide therapy beyond what was used in the STUP protocol. What is your experience and practice pattern in Denmark?
You're talking about to prolong the temozolomide.
That's right.
You know, in grade 3 tumors, the basic randomized study was on 12 months. So we do that in 12 months. But, you know, in US, routinely, they do 12 months temozolomide as an adjuvant setting. But I don't think there's any data that 12 months is better than 6 months. So what we do is that if we still see response after 6 months, we keep treating with temozolomide. If we don't see no change at 6 months, we stop temozolomide. And then also we are maybe a little more aggressive if it's MGMT methylated, because then, you know, the repair of the DNA is less, so you can keep on. But we have patients that we give more than six standard treatments, but that is mostly if we still look at regression in the tumor. So that's how we do it. And I know in US they do 12 months, but there is no data, randomized data, that 12 months is better than 6 months.
Thank you very much, Professor Paulson. I'm afraid we don't have any further questions. So I'd like to thank Professor Paulson and Dr. Rajiv Mangla for your excellent talks. And it was a pleasure to have you at this session at such an early hour in the morning for yourself in Denmark and in New York. And Dr. Aisha, thank you very much for your presentation and for the case discussions. And we look forward to meeting you again on a physical platform, if possible, and if COVID allows us. And until then, take care and be safe. And thank you very much on behalf of the organizing committee of the 19th Shaukat Khanum Cancer Symposium. Bye-bye.
Thank you so much. It was an honor to participate in the discussion. Thank you so much.
Bye.
Thank you.